We looked at recommendations for PrEP regimens. Now, given an HIV-exposed patient, recommend appropriate post-exposure prophylaxis regimen.
So, when it comes to post-exposure, we have occupational and non-occupational post-exposure. So, occupational would be like, in the healthcare setting, for example, if a doctor is, giving, or let's say a pharmacist is giving a flu shot to a HIV-positive patient, and they accidentally get a needle stick on their own hand, that would be an occupational exposure. Whereas non-occupational exposure is something like, if you have a if someone was raped, for example, by a HIV positive person, or which it's those cases will come to the emergency department. So I've seen cases where patients would come to the emergency department after rape, and we would, that's part of the protocol in the emergency department with post-exposure prophylaxis, because it's unlikely to know the status of, that person that was involved. That's just one example. So post-exposure prophylaxis should be started as soon as possible. And the treatment is at a full 4 weeks. So we give them, and this is not that this is different from PrEP, because this is not just a backbone. So this is Truvada plus a third agent. So this is just like treatment. So we have integrase strand transfer inhibitors. So raltegravir and dolutegravir are preferred treatments for post-exposure prophylaxis plus a backbone. So the backbone is Truvada. So the reason we only have these, it's like Truvada as the backbone, is because these are the regimens that have been studied for post-exposure prophylaxis, and it has to be a full 4 weeks or 28 days of treatment. Alternatively, the guideline recommends, and these are the CDC guidelines from 2016, to use the backbone plus boosted darunavir. So ritonavir is a booster for darunavir. And the reason this is an alternative is because of there are more side effects and definitely drug interactions with boosted darunavir. So it is important, because we really want to make sure the patient completes 4 weeks of treatment. It's important to choose regimens that are tolerable. So these integrase inhibitors are, generally speaking, well tolerated. So here's how it works. So if someone has been exposed to the virus, if the exposure risk is negligible, it's not recommended to actually do post-exposure prophylaxis. Especially if you know the source and you know they are HIV negative, then there's no need for treatment. Now, if there is a substantial exposure risk, if it's been more than 72 hours, post-exposure prophylaxis is unlikely to be effective, so it's actually not recommended to treat. What we do instead is that we keep testing for HIV, and if should they test positive for HIV, you just treat the HIV. So that's what we do. But if it's been within 72 hours of exposure, that's when the post-exposure prophylaxis is actually effective. So if you know the source to be HIV positive, you definitely start post-exposure prophylaxis if it's been less than within 72 hours. If the source is not known, then we go case by case. There's when in doubt, we definitely, you should definitely do post-exposure prophylaxis. But so sometimes this is the language the guideline uses, so you could potentially use your clinical judgment and decide if the patient who's been exposed and the source HIV status is not known. It would be up to the clinician's judgment to decide if they want to treat or not. And of course, if should they decide not to treat it, what typically happens is that they just continue monitoring. Should the patient test positive for HIV, they just treat it. Now, this is the 2013 guideline for occupational post-exposure prophylaxis. So this is something that hospitals will have as part of their protocol for their employees which is basically the same concept. So, you know, so back in 2013, raltegravir was the only drug with excellent data. So, if you wanted to use dolutegravir instead of raltegravir, you can. So basically you need a backbone. So Truvada is the backbone plus a third agent, which is an integrase inhibitor. And here are some alternatives. So when it comes to the alternatives, so on the right side you have your backbone. So you have two nukes as your backbone, and then you choose a third agent. So the third agent can be integrase inhibitor, or it can be a boosted darunavir. I know it looks like two agents, but it really is not. This ritonavir is a boosting agent for darunavir. You can also use non-nukes like rilpivirine and etravirine. And also there are other boosted protease inhibitors you can use. So it is recommended that, of course, you're going to check for HIV at baseline. And then it's important to follow up and check for HIV at 6 weeks, 12 weeks, and also 6 months after exposure, after which if all tests are negative, then you can actually rule out HIV.